Professor Chandrika N Wijeyaratne is the Vice Chancellor, University of Colombo. She is a Senior Professor in Reproductive Medicine, Department of Obstetrics and Gynecology, Faculty of Medicine, University of Colombo, Honorary Consultant Physician Endocrinologist, De Soisa Hospital for Women and National Hospital, Colombo, Sri Lanka. The first endocrinologist in Sri Lanka to be appointed to an academic position in 1993 with the distinction of being a pioneer women's health physician in the South Asian region. Her research interests include polycystic ovarian syndrome and insulin resistance in South Asians, fetal programming and intergenerational impact of metabolic risk, gestational diabetes, and other complex medical disorders of pregnancy. She has won multiple national and international awards and has over 80 publications and is a leader in the field of PCOS and GDM.
Ayubowan, greetings from the University of Colombo, and I thank Dr. Sudha and all the organizers for inviting me to join you virtually but truly in spirit. I have always enjoyed my stay at the CMC Vellore and send you my warmest greetings. So the topic for my discussion is essentially on thyroid disease in pregnancy. I was requested to predominantly address subclinical hypothyroidism, but I would like to address some of the related and important issues, particularly on thyroid physiology in pregnancy and the importance of having gestational age-specific thyroid function test interpretation, as well as the abnormal effects on maternal thyroid function on pregnancy. And most importantly, knowing all these to develop a rational approach to managing, particularly in today's day and age of widespread laboratory testing, the fact that we can diagnose subclinical thyroid dysfunction. So first of all, we need to address the fact that the thyroid function in pregnancy should be viewed from a maternal, placental, and fetal point of view, particularly as integrated tri-compartment model. And this is a dynamic process. It changes from time to time during the period of gestation, but particularly the fact that the maternal hypothalamo-pituitary thyroid axis is the mainstay and supplies iodine via the placenta, as well as to an extent of thyroid hormone transport and metabolism. While the fetal thyroid, particularly the HPT axis, matures and develops and to quite an extent becomes independent after the period between 12 to 16 weeks. And thereafter, actually, the fetal thyroid gland's function is reliant on the maternal supply, essentially, of iodine. So, on the whole, there are some confounding variables, particularly the changing hormonal milieu in relation to a normal pregnancy, which affects and alters thyroid function. Particularly the human chorionic gonadotrophin, which acts just like thyrotropin and therefore brings about a slightly thyrotoxic picture, but particularly related to hyperemesis and other conditions of normal pregnancy, or which might be even abnormal. But also the fact that iodine excretion increases and therefore the women tend to have a higher risk of iodine deficiency. Meanwhile, there is an increase of estrogens and thereby the thyroid binding globulin, and therefore variables being changed in terms of the free component of thyroxine, which is the biologically active component. Similarly, in today's day and age, the autoimmunity risks are greater, which I shall address as we go along. And as to whether this is linked to iodine deficiency is one concept, or it may be even iodine excess. In the good old days of iodine deficiency, the chances of developing a goiter during pregnancy was almost considered physiological. But in today's day and age, if you do develop goiters, we need to think of iodine deficiency as much as whether there are other autoimmune related problems. We also need to bear in mind that the placenta can increase the turnover of the thyroid hormones, particularly free T4 and T3, through increased metabolism. So, in an animated fashion, there is an increased demand for thyroxine during pregnancy, no doubt, while iodine excretion through the maternal kidneys, as well as the increased placental turnover, increases is probably the main reason for this demand. While it is very clear that the TSH tends to drop from the natural production of the mother, since the HCG tends to take over the action of this TSH hormone, and therefore it is a high T4 level, but the TSH tends to really be low in the natural and measurable production in the mother. As I stated, the estrogen increases the thyroid hormone pool, including the fact that there is increased plasma volume, and therefore there can be alterations in the free T4 fraction, and therefore that tends to increase the TSH, which is offset mostly by the HCG effect in the early part of pregnancy. Meanwhile, the iodine deficiency can also be further aggravated by an autoimmune process, and we need to bear that in mind in terms of developing hypothyroidism. So there is about as much as 50% increase in the iodine excretion in normal pregnancy, and as much as a 50% increase in the thyroid hormone demand. While the risk of developing autoimmune disease and thereby goiters has about an 18% risk overall, but we need to bear in mind that the fetal brain development is reliant on adequate iodine and thereby in appropriate amounts of free T4 coming initially in the early parts of pregnancy from the mother, which bathes the brain of the baby more or less. And therefore, the fetal brain volume and the IQs are generally attributed to an optimal amount of iodine. Too much and too little would be harmful. So we all know the 3 trimesters and the organogenesis issues, but here we are really concentrating on the neuronal proliferation, and we would appreciate that from about 16 weeks, the fetal thyroid tends to be more or less independent and reliant only on the mother for iodine supply, while the fetal brain development has by then been more or less in completion in terms of neuronal development. And therefore, we need to identify this as an important window of opportunity to bring about a healthier and a more neuropsychologically normal offspring. So if we think of the neurobiology, I'm very grateful to Professor John Lazarus, a very close and long-standing friend of ours from Sri Lanka, to have shared this slide with me, which clearly shows and sums up the importance of adequate thyroid hormone delivery to the fetal neuron, as much as the fact that the fetal brain has receptors for the thyroid hormone, and there are also genetic effects, and the fact that this is a temporal process. We also need to appreciate that there are major immune changes, particularly from immune tolerance to even greater chances of autoimmune disease, and therefore the PPP-TTT, the painless postpartum transient thyrotoxic thyroiditis, which was initially described, where Lazarus and a group were in the forefront of epidemiological studies, which clearly showed that there is a higher risk amongst the pregnant women, particularly in the postpartum, but even in the earlier parts of pregnancy. So overall, pregnancy and thyroid disease, in terms of as to how common they are, There is overt hyperthyroidism occurring in a small fraction, while an overt hypothyroidism occurring even in a lesser number of people, of women of childbearing age. While the antibody development is higher risk amongst women, no doubt, and in pregnancy it is accelerated, while frank hypothyroidism is less common than the isolated hypothyroxemia and the subclinical hypothyroidism. And so that is the main component of the hypothyroidism, of subclinical hypothyroidism. As much as thyroid nodules can develop, and as I mentioned before, the greater chances of a postpartum exacerbation of all autoimmune diseases, including even Graves' disease. Now, what of the outcome of maternal hypothyroidism? We need to bear in mind that there are direct placental effects, and there is fetal growth retardation and a greater risk of preeclampsia, particularly abruptio placentae and preterm birth, all which will attribute towards a greater chance of perinatal loss and also spontaneous miscarriage in those with very severe overt hypothyroidism. So treatment with thyroxine will substantially reduce these complications. There is a large amount of evidence over the last decade and two, and also the fact that there is an offspring IQ being modestly affected through this phenomenon of subclinical hypothyroidism. So we need to appreciate that we need to be watchful. In today's day and age, women tend to go into pregnancy at a later age and lesser chances of fertility, and therefore these pregnancies have to be very closely monitored from a point of view of particularly the high-risk pregnancies as to whether there is a comorbidity with thyroid disease. Now, what of thyroid overtreatment or hyperthyroidism, which may be iatrogenic? We need to appreciate that it can alter skeletal growth and can affect the fetus, and therefore we need to not consciously overtreat, and we cannot be very jocular about it. So we need to monitor the biochemistry, particularly the free T4 levels and a TSH, which needs to be addressed particularly in relation to the gestationally related reference ranges. So we need to bear in mind that in early pregnancy, the TSH tends to come down, and then it will normalize and remain stable into the third and latter part of pregnancy, third trimester, while the free T4 tends to be more or less the same in the more towards the upper quartile. So we need to appreciate this, and we need to have actually identify our own reference ranges, as it can vary from population to population, which was amply shown in the Dutch trials, the Moroccan, the Turkish, and multiple ethnicities. There was a reasonable amount of variation, but overall, we would like the TSH levels to be within the 2.5 milli-international units per liter in the first trimester, taking into account and factoring in the spontaneous rise of HCG, which replicates the action of TSH. So we need to appreciate that there are trimester-specific changes, and often the problem is that doctors who are unaware of this physiological change tend to diagnose women in early pregnancy as being thyrotoxic simply by the low TSH, which is physiological in most instances, and while the total T4 may have been measured and due to the binding globulins is considered high. So we need to appreciate these, and particularly the women who are on thyroxine, we need to encourage them to take a slightly higher dose as determined by the biochemistry, and also in terms of their reliability of compliance and adherence. Now, what of the hyperemesis woman? We need to appreciate that they would have a higher risk of hyperthyroidism, or what we call gestational hyperthyroidism, and thyrotoxicosis to be versus the true hyperthyroidism of Graves' disease. And therefore, some of the differing criteria are the presence of a goiter, an ophthalmopathy, and of course, the specific antibodies for Graves' disease. But the treatment of these are essentially very different, where in gestational thyrotoxicosis, we tend to only prevail upon beta blockers and good hydration, and very often, once the hyperemesis period is over, they normalize and they do not need antithyroid agents. Meanwhile, if it was Graves' hypothyroidism, we need to appreciate it can have multiple effects, both on the mother, even taking into thyroid storm, and these have to be very, very aptly managed, while in the fetus, there is a higher risk of the antibodies crossing across and causing fetal and neonatal Graves. Now, coming back to subclinical hypothyroidism, which is by far the more in numbers of women that we would come across, we need to appreciate the cutoff, which we would prefer in the first trimester to be 2.5. And there were very confounding, the case study and CAT study, which led us a little bit away from these cutoffs. But overall, particularly for the high risk, particularly for those with antibody positive, it would be best to have these form of cutoffs and adjust your thyroxine replacement accordingly. And very often in the early phase pregnancy, those who have not been on thyroxine before, and say, for example, if TSH is closer to 4 in the first trimester, it is a very small quantity of thyroxine that is needed, which may vary from 25 to 50. So what about fertility? Even in males, thyroid dysfunction can affect their sperm production, while in females, thyrotoxic women have menstrual problems and ovulation problems, but by far the hypothyroidism, which can mimic PCOS as well as reduce the fertility, has to be borne in mind. Now, there is a cross connection between subclinical hypothyroidism and the metabolic syndrome, and we know all of us have are well aware that the South Asian women during gestation period are more liable to the metabolic risks of diabetes and gestational hypertension. As you saw, the subclinical hypothyroid woman has a greater risk of preeclampsia and preterm delivery, and therefore, particularly those with high-risk pregnancies, we need to bear in mind and pay due attention to subclinical hypothyroidism. Also, to bear in mind the greater risks of abruption and increased perinatal losses and need for special baby care, which are well shown by large studies and meta-analyses to be substantially reduced had we started them on a very small dose of thyroxine and monitored them closely. So in terms of subclinical hypothyroidism, you will have inappropriately high TSH for the gestational period and a normal free T4, as much as in a small group, you can have isolated hypothyroxemia. And those are the groups that there was a lot of debate as to whether they should be treated or not, but the greater amount of data supports that even the isolated hypothyroxemia, particularly if they have thyroid antibody positive status, microsomal antibody, that they should be treated, and particularly in terms of making sure that it's a healthy offspring. So as I mentioned, the antibody status alone has a higher risk, be it miscarriage, progression to hypothyroidism, preterm delivery, and impaired development and postpartum thyroiditis. So overall, if they are antibody positive, we would encourage the clinicians to keep the TSH as much as possible within the accepted normal ranges. What of iodine? I mean, we fall into the iodine adequate countries in today's age because of iodine supplementation into our salt. But no doubt, if there's iodine excess, we run a risk of autoimmune thyroid disease as much as the dysfunctions, goiters, and even a greater cancer risk. No doubt with a higher pickup rate due to greater use of ultrasounds. But we need to bear in mind that the women need to get enough iodine, and the recommended value is about 250 micrograms. I'm sorry about this busy slide, but overall, The different groups do not encourage universal screening, but in special groups, be it age, be it comorbidities, particularly other autoimmune disease, and so on, and use of amiodarone, lithium, and others in the past, that they would say, and also diabetes, to do the thyroid function as a screening tool in the early part of pregnancy or pre-conception. No doubt, having universal screening is not encouraged in our part of the world because it's not cost effective and we are likely to miss out. And therefore, as you can see, every year they changed their guidelines, but it's essentially targeted case finding and the majority to be screened based on risk factors. So overall, ladies and gentlemen, what I would like to say is that if we do a TSH, we think this woman deserves it in early pregnancy. And if it falls over 2.5 and particularly over 4, we need to bear in mind that we need to treat them as no doubt, not only at 10, but even over 4 is what I would recommend. But the upper limit in thyrotoxicosis will be much more cautious to start treatment, bearing in mind that there is a high risk of gestational toxicosis. So ladies and gentlemen, to conclude, free T4 in the mother is critical for the fetal brain development. Changes are dynamic, particularly in the first trimester, and we need to be conscious of the trimester-specific reference ranges. Hyperthyroidism is uncommon but associated with complications. Subclinical hypothyroidism is associated with neurocognitive delay, and many countries that are iodine sufficient are deficient during gestation when it comes to the individual women, and we need to be conscious of iodine supplementation, and the screening debate still continues. Thank you very much.